Imagine you're on call, late at night. The air's kind of thick with anticipation. Then the doors swing open and a patient comes in. They're clutching their chest, short of breath, a cold sweat beating on their forehead. Every second counts. That feeling, that urgency, is really what we're diving into today.
It's a moment that every one of you as, future medical professionals will undoubtedly face. And understanding what's truly happening in that moment, from the intricate cellular chaos right up to the systemic impact on the body, is absolutely critical for your patients and, let's be honest, for your upcoming exams too.
Absolutely. So our mission for this deep dive is a comprehensive journey into acute coronary syndromes, myocardial infarction, and angina. We're going to give you, hopefully, a detailed exam-ready understanding, covering the pathophysiology, diagnosis, management, drawing from multiple expert perspectives that we've researched.
Yeah, we've synthesized a wealth of information for you. Detailed lectures on MI pathology, the cascading cellular consequences of ischemia, the nuances of angina treatment strategies, the clinical aspects of ACS, and, of course, the biochemical markers that form your diagnostic toolkit.
Right.
We've even peeled back the layers to look at, well, what's often the root of the problem, cholesterol and its pharmacological management. This deep dive is really designed to equip you with the understanding needed to connect all these dots in your mind.
And this isn't just about memorization for your assessments, is it? This is about grasping the why behind the what.
Exactly.
It's about building that solid foundational knowledge that will not only help you ace those crucial exams, but more importantly, prepare you for the realities of clinical practice, where, lives depend on your ability to understand and respond.
So let's unpack this. Let's start at the very core of cardiac ischemia. What exactly is a myocardial infarction, or MI? Because it's so much more than just the common term heart attack. Precisely. A myocardial infarction fundamentally means the irreversible death of cardiac muscle, cardiac tissue necrosis. And it's a stark reality, too. Our sources highlight that in South Africa alone, we see over 130 MIs every single day.
Wow.
Yeah, leading to 33 daily deaths. And this isn't just a local issue. It's a huge public health challenge globally. It remains the leading cause of mortality worldwide.
And what's predominantly driving this devastating process, our sources clearly tell us that over 90% of ischemic heart disease, where blood flow to the heart is restricted, it's a direct consequence of reduced coronary blood flow.
Right.
And that reduced flow is almost always due to obstructive atherosclerotic vascular disease. So atherosclerosis is the major dominant player here.
That's absolutely right. Atherosclerosis is the overwhelming cause, no question. But it's important for you to be aware of that remaining 10%. These less common cases might stem from significant increase in the heart's demand for oxygen, maybe due to a very fast heart rate, like severe tachycardia or really high blood pressure. Or it could be due to diminished blood volume, like in severe hypotension or shock.
Right, shock states.
Exactly. Other contributors could be diminished oxygenation itself, maybe from severe pneumonia or congestive heart failure, or even a diminished oxygen-carrying capacity of the blood, which you'd see in severe anemia or, say, carbon monoxide poisoning. Understanding these broader possibilities is crucial for a comprehensive differential diagnosis when that patient comes in clutching their chest.
Okay, so if atherosclerosis is the main culprit, the 90% cause, what are the risk factors that set the stage for an MI? We can broadly think of them as the unchangeable or constitutional, and the modifiable ones, the ones we can actually do something about, right?
Yeah, that's a good way to think about it.
Yeah.
On the constitutional side, the non-modifiable ones, we're talking about factors like age MIs are overwhelmingly seen in older individuals, with risk really climbing after 65. Then there's race and sex. Males generally have a higher risk than females, especially at younger ages, though, interestingly, that gap narrows quite a bit after menopause.
Mm-hmm.
And, of course, there's a genetic component. If you have a first-degree relative parent, sibling who had early coronary artery disease or stroke, your own risk is definitely elevated.
Okay, and then we get to the modifiable risk factors. This is where we, as clinicians, can truly intervene.
Mm.
What are the big ones here that every student needs to really grasp?
Cholesterol is a huge one, a monumental player, really, and we'll definitely spend some time digging into its role in management later. Beyond that, the absolute core modifiable factors are uncontrolled hypertension, high blood pressure, and smoking.
Smoking, yeah. Always comes up.
Always. And when we look at lifestyle factors like an unhealthy diet, obesity, even chronic stress, or certain personality types like the classic type A, they contribute significantly. And it's also really important to consider a patient's medical history. A previous stroke, for instance, significantly increases their risk.
And what about underlying diseases or specific biomarkers? Are there other flags clinicians should be looking out for?
Absolutely. Underlying diseases like diabetes and accelerated coronary artery disease are major accelerators of atherosclerosis. Our sources also highlight elevated biomarkers like C-reactive proteins or CRPs,
Indicating inflammation.
exactly indicating systemic inflammation, and also elevated plasminogen activator inhibitor 1 or PAI1. These biochemical markers tell us about ongoing inflammatory or thrombotic processes that critically contribute to the overall risk of an MI.
Okay, let's really drill down into atherosclerosis itself, since it's so central to everything we're discussing. The response to injury hypothesis sounds, well, complex. What does that actually mean for our arteries, and how does this whole process kick off?
It basically suggests that atherosclerosis is fundamentally a chronic inflammatory and healing response of the arterial wall to some kind of initial injury to the endothelial cells.
Okay.
Think of the endothelium, that delicate inner lining of your arteries, like paint on a wall. When it gets damaged maybe by high blood pressure, high cholesterol, toxins from smoking, it sets off this complex biological chain reaction. It's not just a simple blockage forming, it's a dynamic, ongoing inflammatory process.
So once that inner lining is damaged, what happens next?
Right.
How do those initial fatty streaks start to form?
Right. Once the endothelium is compromised, it becomes dysfunctional. This allows certain lipoproteins, especially oxidized LDL, the bad cholesterol, to kind of sneak into the intima and media layers of the vessel wall. Our immune cells, specifically monocytes, then migrate into this damaged area. They differentiate into macrophages. Sort of, yeah.
Huh.
They start gobbling up those oxidized LDL particles, turning into what we call foam cells. These lipid-laden foam cells accumulate, and that forms the earliest visible lesion, the fatty streak.
And then this whole process creates a fibrous cap over these deposits, almost like trying to wall it off.
Exactly. This cap is formed by smooth muscle cells synthesizing extracellular matrix. They're trying to wall off that fatty lipid core. But the stability of this cap is absolutely crucial. Our sources differentiate between two really critical plaque types: unstable and stable plaques.
Okay.
Stable plaques have a thick fibrous cap and a smaller lipid core, making them less likely to rupture. But the high-risk, or unstable plaques, they're characterized by a large, soft lipid core and a thin, fragile, fibrous cap. Plus, they have a high density of inflammatory macrophages.
And those macrophages are trouble.
Big trouble, because they release enzymes called matrix metalloproteinases, or MMPs. These enzymes literally degrade collagen and further thin that cap, making it incredibly vulnerable to rupture.
So the devastating complications like erosion, hemorrhage, plaque disruption, ulceration, those are directly related to the instability of that thin cap. That's where the real acute danger starts, isn't it?
Precisely. When an unstable plaque ruptures or erodes, it's like opening Pandora's box. It exposes the highly procoagulant material within the plaque, rich in tissue factor, to the circulating blood. This is the critical, often sudden step that initiates acute thrombus formation. Basically, a blood clot forming right there inside the artery.
That brings us to the broader term, ischemic heart disease, or IHD. How does that fit into this big picture we're painting?
IHD is really an umbrella term. It encompasses several related clinical syndromes, all caused by myocardial ischemia. The fundamental problem is a critical imbalance. The blood supply to the heart simply can't meet the myocardial oxygen and nutritional requirements. And as we mentioned, IHD remains the leading cause of mortality worldwide. It just highlights the enormous scale and impact of this condition.
Yeah, and it's not just about how much of the artery is blocked, say 70% versus 80%, right? The type of plaque, its morphology, its stability also plays a huge role in how severe the ischemia actually becomes.
Absolutely. The severity of ischemia isn't solely dependent on the percentage stenosis, the extent of the occlusion. Changes in plaque morphology, particularly that plaque disruption and the subsequent thrombus formation, are the key determinants of the acute events. Patients presenting with what we call acute coronary syndrome, so unstable angina, MI, or sudden cardiac death, almost always have these abrupt plaque changes and acute thrombus formation as the underlying trigger.
Okay, so we've laid the groundwork with atherosclerosis and IHD.
Now,
Now let's move into the acute event itself, the pathophysiology of a myocardial infarction. how does that unstable plaque or maybe some other trigger lead to a full-blown MI?
It almost invariably starts with an atheromatous plaque undergoing some kind of acute change. This could be a hemorrhage into the plaque itself, erosion of its surface, ulceration, or most commonly, rupture or fissuring of that thin fibrous cap we talked about.
Okay.
Any of these events expose the highly thromogenic subendothelial collagen, and the plaque contents the lipid core, the inflammatory cells, to the circulating bloodstream.
And when that happens, platelets, which are always just floating around, they react immediately and aggressively, like first responders to an injury.
That's the next critical step, and it's often a rapid and catastrophic one. This exposure triggers a swift and strong platelet reaction. They adhere to the site, they become activated, and they aggregate, sticking together. This process is intensely compounded by vasospasm, a sudden, powerful constriction of the blood vessel, and the activation of the coagulation pathway, which rapidly starts building a fibrin clot.
So it's truly a perfect storm for a clot to form, growing really quickly to completely block the artery.
Exactly. A thrombus develops, rapidly expands, and can completely occlude a coronary artery. Think of it like a dam rapidly building up and blocking a river. Now, while thrombus formation on a ruptured plaque is the dominant cause, it's important to remember that other, less common factors can also contribute. Things like severe vasospasm, even without plaque rupture, emboli from other parts of the body lodging in a coronary artery, vasculitis, certain hematologic conditions, or even vascular dissection can also lead to MI. These just highlight the need for a comprehensive differential diagnosis in the acute setting.
Okay, that brings us to the critical timeline of myocyte death. Once that blood flow is cut off, how quickly does the damage to heart muscle cells become irreversible? This seems incredibly important.
It's astonishingly fast, which really underscores the extreme urgency of intervention in these cases. ATP, the cell's energy currency, starts to decline within seconds of complete obstruction. Lactate, that byproduct of anaerobic metabolism, starts accumulating almost immediately because there's no flow to wash it out.
Wow, seconds.
Yeah. And within mere minutes, myocardial contractility ceases. The heart muscle in that area stops pumping effectively. Importantly, at this very early stage, there's probably no cell death yet, but the heart's pumping ability is already severely compromised, potentially leading to immediate heart failure symptoms like shortness of breath.
But the point of no return, the irreversible injury, happens shockingly fast, doesn't it? That's the critical window everyone talks about.
It does. Irreversible myocyte cell death occurs incredibly fast, typically within 20 to 30 minutes of complete coronary artery obstruction. To give you a more precise picture from the sources, ATP depletion starts in seconds, loss of contractility happens in maybe 2 minutes, ATT levels are halved in 10 minutes, and by 40 minutes, they're down to just 10% of normal. This rapid progression of irreversible cell injury means that every single minute counts when a patient is having an MI. And after just 1 hour, microvascular injury damage to the tiny blood vessels within the heart muscle also begins to develop, further complicating potential recovery.
And the specific location of this obstruction matters immensely, doesn't it? Because different coronary arteries supply specific areas of the myocardium. So which areas are most commonly affected, and what does that mean clinically for the patient?
Understanding the anatomy here is absolutely crucial for diagnosis, interpreting ECGs, and predicting prognosis. The left anterior descending artery, or LAD, is the most commonly affected artery. An occlusion here typically impacts the apex of the heart, the entire anterior wall of the left ventricle, and the anterior 2/3 of the interventricular septum. This is often called the widowmaker lesion because of the extensive critical damage it can cause.
Yeah, I've heard that term. And after the LAD, what's next in terms of frequency? Which artery is number 2?
The right coronary artery, or RCA, is the second most commonly affected. Now, in about 80% of individuals, the RCA provides the dominant blood supply to the heart. So an RCA occlusion in a right dominant heart would typically affect the right ventricle, the posterobasal aspect of the left ventricle, and the posterior interventricular septum. In the less common left dominant supply pattern, it would still affect the right ventricle and the posterior basal left ventricle. The left circumflex artery, or LCX, is the least commonly affected major coronary artery. In a right dominant heart, it typically affects the lateral wall of the left ventricle. If the patient has a left dominant system where the LCX is large, it affects the lateral wall of the left ventricle and also the posterior interventricular septum. Knowing these anatomical distributions is just vital for interpreting ECGs and understanding a patient's specific clinical presentation and potential complications.
So with these anatomical considerations, how do we differentiate between a transmural infarct, which affects the whole wall thickness, and a non-transmural or subendocardial infarct?
Okay, so a transmural infarct results from a sustained permanent occlusion of a coronary artery. This leads to necrosis, or cell death, affecting the entire thickness of the myocardial wall in the specific area supplied by that blocked artery. For instance, a complete LAD occlusion often causes a transmural infarct affecting the anterior left ventricle and interventricular septum. It's full thickness destruction.
Right, through the whole wall. And a non-transmural infarct, how is that different? Where is the damage?
Non-transmural infarcts, also called subendocardial infarcts, are typically confined to the inner third, maybe up to the inner half, of the myocardial wall, usually right beneath the endocardium. They're commonly caused by a transient or partial obstruction where maybe some blood flow is still possible, or perhaps by global hypoperfusion, like in severe hypovolemic or septic shock. That kind of global low flow state can lead to a more circumferential subendocardial infarct. These are not full thickness. You can also have what are called microinfarcts, which are tiny occlusions in small intramural vessels scattered throughout the ventricular myocardium, often seen in conditions like vasculitis or microvascular disease.
Okay, so the necrosis itself isn't instantaneous across the whole affected area, even in a transmural MI. How does that zone of necrosis actually progress through the heart wall over time?
That's a great point. The necrosis starts at the endocardial side, the innermost layer of the heart wall. This area is the most susceptible to ischemia because it has the highest oxygen demand, and it's positioned furthest from the coronary arteries supplying blood from the outside.
Makes sense.
From there, the wave of necrosis progresses outwards towards the epicardial edge, the outer surface. Our sources indicate that roughly half of the myocardial thickness can be involved after just 2 to 3 hours of complete occlusion. Full thickness necrosis generally occurs after about 6 hours. Interestingly, a thin layer of myocardium right at the epicardial edge is often spared. It gets some oxygen and nutrients through diffusion directly from the blood inside the cardiac chambers. The healing process, conversely, proceeds from the outside inwards.
What factors influence the ultimate severity and impact of a myocardial infarction? It's clearly not just the size of the initial clot or which artery is blocked, is it? There must be other variables.
No, you're absolutely right. Many factors contribute to the ultimate extent of the damage and a patient's outcome. The specific affected region of the heart, as we just discussed based on the artery, is critical. The extent of collateral blood flow is also hugely important.
Collaterals, you mean like bypass roads?
Exactly. These are small vessels that can develop over time in patients with chronic ischemia, providing an alternative blood supply. They can significantly mitigate damage if an acute occlusion occurs. The duration of the occlusion, was it partial or complete, and how long did it persist, is absolutely vital. Furthermore, the overall size of the perfusion zone affected, the metabolic needs of the affected myocardium at the time of the event, and systemic factors like heart rate, cardiac rhythm, and blood oxygenation levels all play a significant role in determining the infarct's severity and the patient's prognosis.
Now let's talk about the evolution of changes you'd actually see in a heart post-MI, from the macroscopic or gross level down to the microscopic. And was that crucial time frame again for reversible versus irreversible injury?
Yeah.
That seems key.
That first 30 minutes is the absolutely critical window of opportunity. During that initial half hour, any injury to the myocardial cells is potentially reversible. The cardiac myocytes are damaged, yes, but the damage isn't yet permanent. They can recover if blood flow is restored promptly. However, from 30 minutes onwards, the injury becomes irreversible, meaning myocyte death is pretty much inevitable, even if flow is restored later.
So if a patient sadly dies very acutely, say within 3 hours of an MI, would you see anything visually at autopsy with the naked eye, just looking at the heart?
Surprisingly, perhaps, macroscopically or grossly, during the first 46 hours after an MI, you typically see no visible changes in the heart tissue. If a patient dies very acutely, an autopsy might not show any obvious gross changes. You'd really only see the very early signs under a microscope. As time progresses, though, the macroscopic appearance changes quite dramatically. The myocardium first becomes pale, or perhaps dark and mottled. Then it progressively yellows over days as the dead tissue breaks down. By about 7-10 days, the infarct is maximally yellow, often quite soft, and depressed with distinct red-tan margins where inflammation is occurring. After approximately 2 months, you see the end result: a complete, white, shrunken, well-formed scar tissue replacing the dead muscle. That's the final stage of healing.
What about under the microscope? What are the histological changes we'd expect to see hour by hour, day by day, as the heart tissue dies and then tries to heal?
Under the microscope, the changes are much more immediate and distinct. Within the first day, you'll start to see necrotic cardiac myocytes, They lose their nuclei, their structure changes along with significant edema or swelling. Crucially, there's an infiltration of neutrophils. These are the very first wave of immune cells to respond to the tissue necrosis.
The inflammatory response kicking in.
Exactly. By 2 days, the myocytes have fully lost their nuclei, and there is a much more pronounced neutrophil infiltration. At 3 to 4 days, the neutrophilic infiltrate is very dense, indicating complete necrosis of the muscle in that area.
And then the cleanup crew arrives, presumably.
That's right. Around 7–10 days, macrophages, the body's primary cleanup crew, or histiocytes, heavily infiltrate the infarcted area. They diligently work to mop up the necrotic dead cardiac muscle and all the cellular debris. This transitions into the subacute phase, typically around 2 to 3 weeks post-MI. Here you start seeing the formation of granulation tissue, the beginning of scar formation. This involves a further loss of myocytes, the growth of new fragile blood vessels, and the deposition of loose collagen, fibroblasts starting to lay down scar tissue, and sometimes hemosiderin pigment from broken down red blood cells. Our sources also mention that if reperfusion occurs, say with timely PCI or thrombolytics, you might see specific microscopic features like myocyte necrosis with characteristic contraction bands and areas of hemorrhage due to the rapid reintroduction of blood flow to damaged vessels.
Finally, for this section, what are the most common and potentially devastating complications of a myocardial infarction that clinicians absolutely need to be aware of? This is where the acute event can really spiral downwards.
The complications are broad and can be severe, significantly impacting prognosis. Impaired contractility is almost a given, as dead muscle simply cannot contract effectively. This can lead to heart failure. Arrhythmias are very common, ranging from minor atrial issues to life-threatening ventricular dysrhythmias like ventricular tachycardia or fibrillation.
Those sound scary.
They are. One of the most devastating complications is heart muscle rupture, where the weakened necrotic wall actually tears. This can happen through the free wall, leading to rapid hemorrhage into the pericardial sac, cardiac tamponade, and often sudden death, or through the interventricular septum, creating a hole between the ventricles. Patients can also develop an aneurysm of the heart, where the infarcted area thins and bulges outwards over time. Pericarditis, and inflammation of the sac around the heart, is another common inflammatory complication, often occurring days after the MI.
And what about issues with the heart's internal structures, like the valves or clots forming?
You can indeed see infarct expansion, where the infarcted area progressively thins and dilates, which can worsen heart failure. Thrombus formation within the atrium or ventricle, particularly over the area of damaged endocardium, is also a significant risk. These clots can break off and travel elsewhere in the body, causing embolic events like a stroke. Papillary muscle dysfunction, or worse, rupture, although less common, is devastating. The papillary muscles anchor the mitral valve leaflets. If they rupture, it leads to acute, severe mitral regurgitation, where the valve can't close properly, causing sudden hemodynamic collapse. And ultimately, progressive heart failure is a common long-term outcome, as the damaged, scarred heart struggles indefinitely to meet the body's demands.
Now let's zoom in even further, from the whole heart down to the very cells. What's the cellular story of ischemia? How does restricted blood flow actually impact a cardiomyocyte at the micro level, leading to all those macroscopic changes and complications we just discussed?
Okay, so at the cellular level, restricted blood flow creates a rapid and severe crisis for the cardiomyocytes. There are basically 3 immediate consequences happening simultaneously. Firstly, a dramatic decrease in oxygen supply. Obvious but critical. Secondly, there's a decreased removal or washout of metabolic waste products, meaning things like lactic acid buildup inside the cell. And thirdly, myocardial ischemia often leads to a significant increase in sympathetic nervous system activity, whether that's triggered by the intense pain sensation or by alterations in cardiac output. All 3 of these factors contribute to a rapid chain of events that critically compromise cellular function and ultimately viability.
So, starting with the most basic energy currency, ATP production. What happens when oxygen supply drops, and how does that kick off the cascade of cellular damage?
Right. With decreased oxygen, the cell is forced to switch from efficient aerobic respiration to much less efficient anaerobic metabolism to try and produce ATP. This leads to a rapid increase in lactate production. And because blood flow is reduced, this lactate quickly accumulates inside the cell since it can't be washed out effectively. This buildup of intracellular lactate is critical because it actually inhibits key enzymes in glycolysis, like glyceraldehyde 3-phosphate dehydrogenase, further reducing the cell's already compromised ATP production, so the cell plunges into a profound energy deficit very quickly.
And how does that ATP depletion affect the cell's basic maintenance functions, its ability to just keep itself alive and stable?
The sodium-potassium ATPase pump, which is the largest single consumer of ATP in pretty much any cell, is severely compromised. This pump is absolutely vital for maintaining the correct ionic balance across the cell membrane. It actively pumps sodium out and potassium in. When it malfunctions due to lack of ATP, you get an increase in extracellular potassium, which is one of the key reasons we see characteristic ST segment elevation on an ECG. You also get a significant increase in intracellular sodium, making the cell electrically unstable and much more prone to arrhythmias.
Right.
As ATP is further depleted, it breaks down into ADP and then AMP. This AMP can be further processed into compounds like hypoxanthine and xanthine. This process contributes to increased reactive oxygen species, or free radicals, which cause direct damage to cell membranes and proteins. Interestingly, adenosine, hypoxanthine, and xanthine, these breakdown products, are all believed to contribute to the actual angina pain felt by patients.
You also mentioned sympathetic activation. How does that play into this metabolic chaos? Does it help or make things worse?
It generally makes things worse, paradoxically. Sympathetic activation, often a reflex response to the pain and stress of ischemia, ramps up myocardial metabolism. It increases the demand for oxygen and energy, further compounding lactate production in an already starved cell. Additionally, the breakdown product of cyclic AMP, which is the key second messenger for beta-adrenergic activation from adrenaline and noradrenaline, also contributes to the increase in AMP concentrations, further accelerating the cellular energy crisis.
So we've covered decreased ADP and the resulting ionic issues. But what are the direct consequences of that increased lactate production you mentioned? And how does it lead to calcium overload, which sounds like a major problem for heart cells?
Increased lactate, it directly means increased lactic acid. This translates to a significant increase in hydrogen ion, H+, concentration within the cell, leading to a dangerous decrease in intracellular pH. The cell becomes acidic. The cell desperately tries to correct this acidosis by activating the Na plus H plus exchanger pump on its membrane. This pump pushes H plus out, but in exchange, it pulls sodium in. So while it attempts to normalize pH, it dramatically increases cytoplasmic sodium, further compounding the problem already caused by the dysfunctional NAC ATPase.
And then that excess sodium somehow brings in calcium, creating a kind of vicious cycle, doesn't it?
Precisely. This increased cytoplasmic sodium then activates another exchanger, the sodium-calcium exchanger, NCX. This pump works in reverse mode under these conditions, pumping out the excess sodium, but in turn bringing in a significant amount of calcium from outside the cell. This leads to a critical increase in cytoplasmic calcium.
Okay, so calcium starts flooding the cell.
Right. And to make matters even worse, the sarcoplasmic reticulum, SR, calcium ATPase pump CIRCA, which normally pumps calcium back into the SR storage organelle to allow for muscle relaxation, also requires ATP to function. If CIRCA is compromised due to low ATP, calcium remains trapped in the cytoplasm, further escalating intracellular calcium levels. On top of all that, sympathetic activation itself directly stimulates calcium influx through L-type channels and promotes calcium release from the SR, driving even more calcium into the cytoplasm. This massive calcium overload, combined with increased free fatty acids released due to sympathetic-induced lipolysis, directly damages cell membranes, contractile proteins, and especially the mitochondria, the cell's powerhouses.
This all sounds like an absolute disaster for the heart muscle's fundamental ability to contract and relax properly. Let's talk about the sarcolemma and excitation-contraction coupling. How is that normal, tightly regulated process completely thrown into disarray by ischemia?
Okay, so normally, for the heart to beat, an electrical signal travels down the T-tubules, opening L-type calcium channels. A small amount of calcium enters the cell, which then triggers the release of a massive amount of calcium from the sarcoplasmic reticulum, SR, through specialized channels called ryanodine receptors, RRR. This flood of calcium then interacts with the contractile proteins troponin and tropomyosin, allowing actin and myosin to bind and cause muscle contraction. For relaxation, the CIRCA pump efficiently pumps that calcium back into the SR, ready for the next beat. It's a beautiful, finely tuned process.
So what goes wrong in ischemia? How does it lead to both stiffness and weakness in the muscle? That seems counterintuitive.
Well, the sympathetic activity, ironically, initially aims to increase contractility by increasing calcium flow into the cell through those L-type channels and making the RIRRs release more calcium. But the critical problem is the plummeting ATP levels. With less ATP available, the CIRCA pump simply can't efficiently pump calcium back into the SR. This has two major detrimental consequences for heart function. Firstly, more calcium is left behind lingering in the cytoplasm. This leads to decreased relaxation and a stiffer, less compliant muscle. This is what we call a diastolic problem, impaired filling. Secondly, with less calcium successfully pumped back and stored in the SR, there's less available for release during the next cycle. This results in a decreased strength of contraction, a systolic effect, impaired pumping. So the net result is this terrible combination of increased resting cytosolic calcium causing stiffness and impaired calcium release causing weakness, both impaired relaxation and contraction.
And all these intricate cellular issues directly impact the contractile machinery itself, the very actin-myosin interactions that make the heartbeat. What's happening there at the most basic molecular level?
You're right, it goes right down to the molecular motors. Without sufficient ATP, the myosin head can't efficiently detach from the actin filament after a power stroke. This hinders relaxation and contributes to that muscle stiffness. Then the increased lactate and H+ ions from anaerobic metabolism significantly decrease intracellular pH. This acidity directly and negatively impacts calcium's ability to bind to troponin C, meaning less effective triggering of the contraction cycle. And there's more. Increased inorganic phosphate, which accumulates as ATP is broken down, further inhibits the myosin head from strongly binding to actin, again reducing the heart's ability to generate force and contract. Even the increased free fatty acids resulting from sympathetic activity stimulating fat breakdown seem to interfere with cross-bridge formation, though the exact mechanism there isn't fully clear.
So, put simply, all of these cellular changes, the energy crisis, the ion imbalances, the calcium overload, the pH drop, they all directly lead to a decreased ability of the heart muscle to contract effectively. How does that translate into the overall physiological function of the heart that we actually see clinically in a patient?
The widespread damage to the cellular machinery and the compromised contractile mechanisms directly manifest as a decreased force of contraction and also a decreased ability of the heart muscle to relax properly. Physiologically, this translates directly into things we can measure. Reduced systolic pressures, meaning the heart can't pump blood out as effectively, and increased ventricular and diastolic pressures, because the stiff, non-relaxing heart can't fill properly between beats.
Right, the filling pressure goes up.
Exactly. The consequences for overall cardiac function are profound. Decreased cardiac output due to the reduced contraction strength, and increased end diastolic pressures due to the impaired relaxation. These are both classic hallmarks of heart failure. An ischemic ventricle, if the damage is extensive enough, may ultimately fail to pump effectively enough to sustain the body's needs.
So understanding these incredibly intricate cellular pathways isn't just for academic interest, is it? It directly informs how we approach treatment. It forms the very rationale for our pharmacological interventions, doesn't it?
Absolutely. It's not just academic. The treatments we use are precisely targeted at interrupting or mitigating these underlying cellular disruptions. For instance, to address the primary problem, the decreased oxygen supply and the buildup of toxic metabolites, our primary goal is always to increase perfusion as quickly as possible.
Restore blood flow.
Yes. This involves administering drugs like nitrates to dilate vessels, aspirin and other antiplatelets to stop clot formation, or powerful clot busters like thrombolytics to dissolve existing clots, and of course providing supplemental oxygen. Then, to counter the aggravating effects of that sympathetic nervous system overactivity and reduce the heart's workload and oxygen demand, we use beta-adrenergic receptor blockers. And finally, to counteract the problematic increased intracellular calcium concentration, which cripples both contraction and relaxation, we can administer L-type calcium channel blockers, which reduce calcium influx into the cardiomyocytes. These interventions are all designed based on understanding the cellular pathophysiology, aimed at restoring the delicate cellular balance and minimizing the extent of permanent damage.
Okay, let's shift gears now from the acute life-or-death scenario of an MI to the more chronic but equally important side of ischemic heart disease, angina pectoris, literally pain in the chest. This is often a warning sign, isn't it? Something that precedes a full MI sometimes.
Very often, yes. Angina pectoris signifies transient temporary ischemia in the heart muscle. It's often referred to nowadays as stable coronary artery disease, or SCAD if it's predictable. The underlying pathology is, once again, usually significant cholesterol buildup and atherosclerosis, typically causing a 70% occlusion or more in one or more coronary arteries. Unlike an MI, it's not typically a full, sustained blockage leading to cell death, but it's a severe narrowing that significantly limits blood flow, especially when the heart's demands increase.
So it's not a full blockage like an MI, but enough to cause issues, especially with exertion. And there are different types of stable ischemic heart disease or different patterns of angina.
Exactly. The most common type is chronic stable exertional angina. This occurs predictably with physical exertion or sometimes significant emotional stress. Here, the heart's demand for oxygen increases, but the severe coronary artery occlusion prevents adequate blood delivery to meet that demand, causing the characteristic chest pain or discomfort. Then there's angina at rest, which is actually a feature of unstable angina, and that falls under the umbrella of acute coronary syndrome, which we discussed earlier.
Right.
Here, angina occurs even without exercise, often due to temporary plaque disruption and transient platelet plug formation that might then resolve. This is much more serious as it can progress to a non-STEMI or STEMI, depending on the severity and whether there's evidence of myocardial necrosis with biomarker elevation.
And the third type, Prinzmetal's, sounds quite different from the others. Less common.
Yes. Prinzmetal's variant angina or vasospastic angina is less common, but very distinct and important to recognize. It's caused by temporary, often unpredictable coronary artery vasoconstriction. The artery itself suddenly clamps down or spasms, which severely compromises blood supply and leads to angina, often occurring at rest, sometimes even waking patients from sleep. It's primarily a supply problem due to the spasm, not necessarily a demand problem related to a fixed atherosclerotic blockage, although underlying atherosclerosis can be present too.
How does this transient ischemia actually cause the pain of angina? And what's happening with that critical oxygen balance in the heart during an episode?
It's fundamentally an imbalance between supply and demand. During periods of exertion or stress, the heart's energy consumption increases significantly. Normally, healthy coronary arteries would dilate quite effectively to meet this increased demand. But with a significant occlusion, say 70% or more, that necessary dilation just isn't possible. The flow is limited. This forces the affected heart muscle to switch to inefficient anaerobic metabolism, which, as we discussed at the cellular level, generates byproducts like hydrogen ions, acid, and other substances like adenosine and potentially bradykinin. These substances then activate sensory pain fibers in the heart, signaling the profound lack of oxygen to the brain, which is perceived as angina. From a pharmacological standpoint, our primary aim here in stable angina is usually to decrease the heart's demand, as significantly increasing supply past a fixed severe occlusion is often very challenging.
What are the key determinants of myocardial oxygen consumption that we can actually modify with drugs to alleviate angina? What factors drive how much oxygen the heart uses?
The most easily modifiable factors pharmacologically are heart rate and contractility. Reducing heart rate directly decreases oxygen consumption per minute and also gives the heart more time to fill and perfuse during diastole. Reducing the heart's contractile force or inotropy decreases stroke volume and thus overall oxygen consumption. But by far, the most important determinant for myocardial oxygen consumption is left ventricular wall stress. This is elegantly governed by Laplace's law, which relates wall stress to pressure, radius, and wall thickness.
Okay, Laplace's law. So how does wall stress relate to oxygen consumption, and what are the two main factors contributing to wall stress that we can influence?
Wall stress essentially represents the force distributed across the heart wall during contraction. It involves two main factors we can target with drugs. And diastolic pressure volume, often called preload. This is the pressure stretching the ventricle just before it contracts. The more blood returning to the heart, venous return, the more the heart stretches and the more oxygen it consumes to generate the necessary force. So reducing venous return, for example, by dilating the venules, the small veins decreases left ventricular and diastolic pressure, LVADP, and significantly reduces oxygen consumption.
Makes sense. Less stretch, less work. What's the other factor?
The second major factor is systolic resistance, or afterload. This is the pressure or resistance the left ventricle must overcome to eject blood into the systemic circulation, largely determined by total peripheral resistance, TPR. Increased TPR, maybe from sympathetic activity during exercise or stress causing vasoconstriction, directly increases the heart's workload during systole, and thus its oxygen consumption, potentially precipitating angina. During an angina attack, oxygen demand can accelerate dramatically, maybe 2 to 5 times baseline, but the supply is severely limited by that fixed occlusion, creating the critical imbalance that causes pain.
So the goal is always to ease the burden on the heart, either by trying to improve supply where possible, or more often, by reducing demand. This brings us squarely to the pharmacological management of ischemic heart disease, directly targeting these cellular and physiological effects. Let's start with organic nitrates, like nitroglycerin. They're a real cornerstone of angina therapy, aren't they?
Absolutely. Organic nitrates are essentially nitric oxide, or NO, donors. Their mechanism of action is quite elegant. They release NO, which then activates an enzyme inside smooth muscle cells called guanylate cyclase. This, in turn, increases the concentration of cyclic GMP, or cGMP. CGMP then acts as a second messenger, causing widespread smooth muscle relaxation leading to vasodilation. This affects both arteries and, critically and predominantly, veins.
And what's the main impact of that vasodilation, especially on the venous side? Why is that so helpful in angina?
The primary and most rapid impact is on the venous system. Nitrates dramatically increase venous capacitance. They relax the veins, causing more blood to pool in the periphery, in the legs and arms. This means less blood returns to the heart. This directly decreases end diastolic pressure and volume-reducing preload, which rapidly and significantly reduces myocardial oxygen consumption. So the heart simply doesn't have to work as hard to pump the blood that does return. They also cause some coronary vasodilation, which can help improve blood flow to the heart muscle itself, increasing its coronary reserve, especially in areas served by non-critically stenosed vessels or where spasm is involved. These effects are all related to CGMP, causing less phosphorylation of myosin light chain in the smooth muscle cells, leading to muscle relaxation.
What are the different types of nitrates we typically use, and for what specific clinical scenarios? Are there short-acting and long-acting ones?
Yes, there are. For short-acting effects, primarily used to abort an acute angina attack that's happening right now, we have glycerol trinitrate, GTN, often called nitroglycerin. It's available intravenously for emergencies or much more commonly as a sublingual tablet or buccal spray for quick relief right when symptoms start. Its half-life is very short, maybe 5-10 minutes. Isosorbide dinitrate, ISDN, can also be given sublingually. It bypasses first-pass metabolism in the liver for quick action and has a sort of mixed short to moderate duration effect.
Okay, so those are for acute relief. What about prevention?
For long-acting prophylaxis, meaning prevention of angina attacks, not treating an acute one, we typically use isosorbide mononitrate, ISMN. This has excellent oral bioavailability, meaning it's well absorbed when taken as a pill, and it's protected from that first-pass liver metabolism. It has a longer half-life, usually around 6 to 8 hours, allowing for once or twice daily dosing for sustained protection.
Now, there's a very, very important drug interaction here that every medical student absolutely must know about. Sildenafil or Viagra and similar drugs. Why is combining these with nitrates so critical and potentially life-threatening? This comes up on exams all the time.
This is an absolutely critical point, potentially life-threatening, and yes, a favorite exam question. Sildenafil and other PDE5 inhibitors, like tadalafil, Cialis, or vardenafil, Levitra, work by inhibiting phosphodiesterase type 5, which is the enzyme that normally breaks down CGMP. Nitrates, as we just discussed, increase the production of CGMP. So when you combine them, you block the breakdown and increase the production of CGMP. This leads to a massive, uncontrolled buildup of CGMP, which causes profound, excessive vasodilation and a precipitous, dangerous drop in blood pressure. This severe hypotension can trigger a dangerous reflex sympathetic response, increasing myocardial oxygen demand dramatically, potentially causing an acute MI, syncope, or even sudden death. Patients must be strictly warned to avoid PDE5 inhibitors for at least 24 hours or 48 hours for longer-acting ones like tadalafil.
And what are the common adverse effects of nitrates themselves that patients might experience even when used correctly?
Headaches are very common, often described as throbbing due to vasodilation in the temporal arteries in the head. Tachycardia, or a fast heart rate, can occur reflexively due to the drop in blood pressure. Paradoxically, this increases oxygen consumption and might actually worsen angina in some cases, sometimes requiring a beta blocker to mitigate it. Hypotension, especially postural hypotension causing dizziness on standing, is also a common risk due to the widespread vasodilation. Flushing can also occur.
Okay, moving on to beta blockers, another cornerstone of angina management, especially chronic stable angina. How do they help the heart, and what's their primary impact on oxygen consumption?
Beta blockers primarily work by blocking beta-1 adrenergic receptors, which are particularly abundant in the ventricular myocytes of the heart. Blocking these receptors antagonizes the effects of adrenaline and noradrenaline. This directly reduces two key determinants of myocardial oxygen consumption: heart rate and contractility. By slowing the heart rate, they give the heart more diastolic time to fill and perfuse the coronary arteries, and by reducing contractility, negative inotropy, they decrease the force with which the heart pumps, lowering its energy expenditure. They effectively lower the double product, which is heart rate multiplied by systolic blood pressure, an excellent clinical indicator of myocardial oxygen consumption.
But they don't actually increase coronary blood flow, do they? That's a crucial distinction from the nitrates we just talked about.
That's a crucial caveat and an important point to remember. Beta blockers do not directly increase coronary blood flow. In fact, by reducing contractility and heart rate, they might even slightly reduce flow demand. This means they are primarily useful for exercise-induced angina, where the issue is one of the heart's demand outstripping a fixed, limited supply due to atherosclerosis. They are also highly beneficial post-MI to prevent adverse cardiac remodeling and reduce mortality, and are often used in conditions like supraventricular tachycardias and atrial fibrillation to control the ventricular rate.
Which beta blockers are commonly used?
Common examples include the beta-1 selective agents like bisoprolol and atenolol, which have the most evidence for use in ischemic heart disease. Carvedilol, which also has alpha-blocking properties, is often used in heart failure but also has benefits post-MI. Metoprolol is another common one. Importantly, though, beta blockers are generally contraindicated, or at least used with extreme caution, in vasospastic or Prinzmetal's angina.
Why is that?
Because blocking beta-2 receptors, which cause vasodilation in coronary arteries, even though beta-1 is dominant in the heart muscle, can leave alpha receptor-mediated vasoconstriction unopposed, potentially worsening the coronary vasospasm and making the angina attack more severe. So generally avoided in pure vasospastic angina.
So if beta blockers aren't good for Prinzmetals, what is? And how do calcium channel blockers or CCBs fit into the picture for angina management? Are they useful for spasm?
Yes, calcium channel blockers are very useful for all types of angina, and they are particularly effective in Prinzmetal's angina precisely because they can directly relax coronary smooth muscle, relieving and preventing coronary artery spasm. Their mechanism involves blocking L-type calcium channels, which are found in both the heart muscle cells, cardiomyocytes, and the smooth muscle cells of blood vessels. Blocking these channels leads to a reduction in heart rate and contractility, similar in effect to beta blockers, but also, crucially, a significant reduction in total peripheral resistance, or TPR, by relaxing peripheral arterioles, vasodilation. Lowering TPR reduces afterload.
The pressure the heart pumps against.
Exactly. Reducing afterload means the heart doesn't have to work as hard to pump blood out during systole, thereby reducing oxygen consumption during that phase of the cardiac cycle.
And there are different types of CCBs, just like with nitrates and beta blockers.
Yeah.
Each with slightly different effects, correct?
Yes, broadly we categorize them into two main groups, and the distinction is important. The non-dihydropyridines, such as diltiazem and verapamil, have a more prominent effect on reducing heart rate, negative chronotropy, and contractility, negative inotropy, although they are also potent vasodilators. The dihydropyridines, like navedipine, amlodipine, and felidipine, primarily relax arterioles and are generally more potent peripheral vasodilators, with less direct effect on heart rate and contractility at usual doses, though reflex tachycardia can occur with some short-acting ones. Both types contribute to angina relief by reducing oxygen demand and sometimes increasing supply, especially in spasm, but their specific impact on heart rate and contractility differs, guiding our choice based on a patient's overall clinical picture, like whether they also need heart rate control.
So given all these options, nitrates, beta blockers, CCBs, what about combination therapy for stable ischemic heart disease? When do we combine them, and what are the synergistic effects we're trying to achieve?
Combination therapy is frequently used, especially when single-agent therapy isn't providing adequate symptom control. The goal is to provide more comprehensive relief by targeting different mechanisms, and sometimes combinations can help mitigate potential side effects from individual drugs. A very common and effective combination is a beta blocker plus a long-acting nitrate, for example, atenolol or bisoprolol, combined with isosorbide mononitrate.
What's the benefit there?
A key benefit is that the beta blocker prevents or blunts the nitrate-induced reflex tachycardia, which is helpful, as that reflex tachycardia would otherwise increase oxygen demand. Both drugs contribute to decreasing systolic blood pressure, further reducing the heart's workload. While beta blockers might slightly increase diastolic filling time and nitrates might decrease it, and beta blockers can increase preload while nitrates decrease it, the net effect on end diastolic pressure tends to be neutral or favorable. Both provide excellent protection against ischemia via different mechanisms, reducing demand versus reducing preload vasodilation. This combination is an excellent strategy for patients with refractory stable IHD.
What about combining a non-dihydropyridine CCB with a nitrate? Is that a good option, maybe if someone can't take a beta blocker?
Yes, for patients who can't tolerate beta blockers, for example, due to asthma or severe peripheral vascular disease, a non-dihydropyridine CCB like verapamil or diltiazem combined with an organic nitrate is a good alternative. The CCB decreases heart rate and contractility, while nitrates might cause a slight reflex increase in heart rate, often leading to a relatively neutral effect on heart rate overall. Both will decrease systolic blood pressure and left ventricular diameter, preload reduction from nitrate, afterload reduction from CCD. both increase coronary vasodilation and provide ischemia protection. This combination is often chosen when heart rate control is needed without using a beta blocker.
And what about combining a dihydropyridine CCB like amlodipine with a nitrate? Is that a common or ideal strategy?
This combination, for example, amlodipine plus an organic nitrate, is generally considered less ideal, though it certainly can be used, particularly if blood pressure control is also a major goal. The main concern is that both potent dihydropyridine CCBs, especially short-acting ones, less so with amlodipine, and nitrates can potentially cause reflex tachycardia due to significant vasodilations.
Right, canceling out the benefit.
Potentially, yes, as that tachycardia increases myocardial oxygen consumption. While both do decrease systolic BP, reducing afterload and preload respectively, and increase coronary blood flow, protecting against ischemia, the potential for an additive effect on heart rate makes it somewhat less favorable than combinations involving beta blockers or non-dihydropyridine CCBs, unless the heart rate is carefully monitored or perhaps a beta blocker is also used, triple therapy.
Okay, we've discussed the overall picture of ischemic heart disease, the underlying mechanisms, and the treatments for stable angina. Now let's bring it all together by clinically defining acute coronary syndrome, or ACS. What exactly does that term encompass, and how do we differentiate between its critical components in the emergency setting?
Right. Acute coronary syndrome, or ACS, is really a spectrum of clinical presentations. It's almost always triggered by the acute rupture or erosion of an atherosclerotic plaque, with subsequent partial or complete thrombosis, clot formation in a coronary artery. ACS includes three main conditions that are vital to differentiate quickly because management differs: unstable angina, UA, non-ST elevation myocardial infarction, NCTMI, and ST elevation myocardial infarction, STEMI.
So how do we distinguish unstable angina from MSTEMI?
Huh.
They can present very similarly with chest pain at rest, can't they? What's the key differentiator?
You're right, the presentation can be very similar. The critical differentiation is based on the severity of symptoms and, most importantly, the presence or absence of specific biomarkers of myocardial necrosis, essentially, blood tests showing evidence of heart muscle death. In NSTEMI, cardiac troponins are elevated, indicating that some degree of myocardial damage or infarction has occurred. In contrast, in unstable angina, the cardiac troponins remain normal, even after hours of ischemic chest pain, indicating ischemia without infarction. ECG changes can be similar for both, often showing ST depression or T-wave inversion, but the troponin level is the key.
And STEMI is the most severe.
STEMI represents a complete or near-complete and persistent occlusion of a coronary artery, leading to transmural infarction. It's a distinct emergency. It typically presents with severe ongoing chest pain, specific and striking ST segment elevation in contiguous leads on the ECG, indicating full-thickness injury, and markedly elevated cardiac enzymes, confirming extensive myocardial necrosis.
Let's quickly re-emphasize the risk factors for ACS, as they're critical to understanding who is most vulnerable to these acute events. We touched on these earlier when discussing atherosclerosis, but it's worth reinforcing them in the context of the acute syndrome.
Definitely. The risk factors are largely the same. The non-modifiable ones include increasing age. Remember, nearly 80% of coronary heart disease occurs in people aged 65 and older. Gender also plays a role, with men typically prone to MIs at a younger age than women, though women's risk increases significantly after menopause. And a strong family history is significant, particularly if a first-degree relative experienced early coronary artery disease or stroke, for example, before age 55 in males, 65 in females.
And the modifiable factors, the ones we can actually address through lifestyle or medication.
Smoking is a huge one. Nicotine and other toxins rapidly increase adrenaline and noradrenaline release, leading to vasoconstriction, increased heart rate, and increased oxygen demand, all of which stress the heart. Smoking also makes blood more prone to clotting by stimulating platelets and damaging the endothelium. Critically, quitting smoking can lower the risk of an acute event by a remarkable 50% in just 1 year.
That's significant.
It really is. Hypertension, or high blood pressure, significantly increases the left ventricular afterload, the pressure the heart works against. Over time, this leads to the heart muscle thickening, hypertrophy, and eventually dilating, which reduces its pumping function. And as we'll discuss more later, diabetes and hypercholesterolemia, high cholesterol, both contribute powerfully to endothelial dysfunction, accelerating the entire atherosclerotic process and increasing plaque vulnerability.
Now let's revisit the detailed pathophysiology of ACS, especially that critical interplay between endothelial dysfunction, plaque disruption, and thrombus formation that leads to the acute event. How does it all unfold?
The process is a continuous one, really, driven by ongoing plaque formation in the intima of large and medium-sized arteries. Those traditional risk factors we just mentioned, and even some other conditions like chronic inflammation or HIV, cause persistent endothelial dysfunction. This dysfunction is key because it means the endothelium, the inner lining, can no longer properly regulate blood vessel tone, vasodilation constriction, or prevent clotting effectively.
What characterizes that dysfunction?
It's characterized by reduced bioavailability of nitric oxide, NO, which impairs vasodilation, and increased production of endothelin-1, which promotes vasoconstriction and clotting. It also leads to increased expression of adhesion molecules on the endothelial surface, making the blood vessels sticky for circulating inflammatory cells like monocytes. The whole environment becomes pro-inflammatory and prothrombotic.
And how do these initial endothelial changes lead to the development of that vulnerable plaque that eventually causes ACS?
Right, with damaged endothelium, monocytes adhere to these adhesion molecules and migrate into the subendothelium. There they differentiate into macrophages. These macrophages then avidly ingest oxidized LDL cholesterol, transforming into those characteristic foam cells, which accumulate to form the fatty streaks we discussed earlier. Activated macrophages further release chemoattractants and inflammatory cytokines, like monocyte chemoattractant protein 1, MCP1, and TNF-alpha, which recruit even more macrophages and also stimulate smooth muscle cells to migrate from the media layer into the intima. These smooth muscle cells then synthesize extracellular matrix components like collagen, forming that fibrous cap over the growing lipid core.
And then, the critical moment, plaque disruption. How does that usually happen, and what's the immediate catastrophic consequence?
Plaque disruption, the rupture or erosion of that cap, is often caused by matrix metalloproteinases, or MMPs. These are enzymes released predominantly by the inflammatory macrophages within the plaque. These MMPs digest the extracellular matrix, the collagen framework, thinning and weakening the fibrous cap, making it susceptible to rupture, especially at the shoulder regions where stress is highest.
And once it breaks?
Once this fragile plaque ruptures or erodes, the highly thrombogenic subendothelial matrix, which is incredibly rich in tissue factor, a potent procoagulant, is suddenly exposed to the circulating blood. This immediately triggers rapid platelet adhesion, activation, and aggregation at the site, forming an initial platelet plug. Simultaneously, the exposed tissue factor powerfully activates the coagulation cascade, leading to the formation of a fibrin mesh that reinforces the platelet plug, resulting in a stable thrombus or blood clot.
Are all thrombi the same? Or are there different types that might lead to different clinical outcomes, like partial versus complete blockage?
That's a good point. No, there are broadly two important types of thrombi recognized. One is a platelet-rich white clot, which typically forms in areas of high blood flow and high shear stress, like over an eroded but not fully ruptured plaque. These often cause partial occlusion and are associated more with unstable angina or anstemi. Then there's a fibrin-rich red clot, which forms due to a fully activated coagulation cascade, often in areas of decreased blood flow or stasis. Red clots are often superimposed on white clots and commonly cause total or near-total occlusion of the artery. These are typically responsible for STEMI.
So the pathophysiology of ACS is really this dangerous interplay between a sudden critical decrease in oxygen supply to the heart muscle and potentially an increased oxygen demand that the heart just cannot meet.
Exactly. The decreased oxygen supply, whether it's from a severe underlying flow-limiting stenosis that becomes critical, or more acutely from plaque rupture or erosion with subsequent thrombus formation, combined often with an increased oxygen demand, maybe due to pain, anxiety, or exertion preceding the event, results in a profound myocardial demand-supply mismatch. This leads to ischemia, which the patient experiences as angina. If this ischemia is severe and prolonged enough, typically more than 20-30 minutes, it results in irreversible necrosis and destruction of myocardial tissue, culminating in a full myocardial infarction and STEMI or STEMI.
Okay, so when a patient presents to the emergency department with suspected ACS,
Yep.
what's the initial clinical assessment process? It sounds like urgency is absolutely paramount.
Urgency is the name of the game. These patients are considered high priority and must be triaged immediately, with evaluation and treatment following a predetermined, evidence-based, institution-specific chest pain protocol. The initial assessment involves a rapid but focused history, asking key questions about the chest pain and associated symptoms, and a thorough but focused clinical examination. Special investigations, primarily the ECG and cardiac biomarkers, are then ordered urgently, guided by the initial assessment and the differential diagnoses you're considering.
What are the classic characteristics of anginal pain that you'd be looking for in the history to guide your diagnosis towards ischemia?
Ischemic pain is typically described as a poorly localized, heavy, squeezing, crushing, or oppressive chest discomfort, often felt substernally. It's usually not sharp, stabbing, or pleuritic, worse with breathing, nor is it typically reproducible by pressing on the chest wall, musculoskeletal pain. Patients often cannot localize it precisely with a single fingertip. They might use a clenched fist over their sternum Levine sign. They might describe it as the worst pain ever, or like an elephant sitting on my chest. It's classically precipitated by physical exertion, emotional stress, or sometimes a heavy meal or exposure to cold, and is usually relieved by rest or sublingual nitroglycerin within minutes, though relief with nitro doesn't definitively rule in or out ACS. It commonly radiates typically to the left shoulder, down the inner aspect of the left arm or sometimes both arms, or up into the neck, jaw, or teeth. And it may be associated with other crucial symptoms like nausea, vomiting, profuse sweating, diaphoresis, shortness of breath, or lightheadedness.
And what specific presentations in the history would strongly suggest unstable angina, which is part of the ACS spectrum and indicates high risk?
Unstable angina typically exhibits one or more of three principal patterns. First, new onset angina that is severe, limiting activity, and occurred less than, say, 2 months previously. Second, angina occurring at rest and lasting more than 20 minutes. Or third, a crescendo pattern, meaning the angina is rapidly increasing in intensity, duration, or frequency compared to the patient's previous stable pattern. Any of these are red flags for plaque instability and an impending or ongoing acute event.
Of course, not all chest pain is cardiac, even severe chest pain. What are some key differential diagnoses for chest pain that clinicians absolutely must consider to avoid potentially catastrophic misdiagnosis?
It's crucial to consider a broad range of potentially life-threatening non-ischemic causes of chest pain. These include other cardiovascular emergencies like a life-threatening aortic dissection, which can mimic MI pain but requires vastly different management. Also, pulmonary embolism, another killer, pericarditis, inflammation of the sac around the heart, and myocarditis, inflammation of the heart muscle itself, can also cause chest pain. Beyond cardiac and vascular causes, you must consider serious pulmonary causes like pneumonia or pleurisy, gastrointestinal causes like GERD, esophageal spasm, esophagitis, peptic ulcer disease, or acute cholecystitis, gallbladder inflammation. And even chest wall musculoskeletal disorders or psychiatric conditions like panic attacks can present with chest pain. A thorough history and focused exam are key to navigating these differentials.
What specific physical examination findings might point you towards an MI or one of these other serious diagnoses in the acute setting? What are you looking for?
On physical exam, you might observe signs of sympathetic nervous system activation like diaphoresis, sweating, or pallor. You need to check the vital signs carefully. Look for abnormalities in blood pressure, either hypotension, which is often a poor prognostic sign suggesting cardiogenic shock, or hypertension, which increases cardiac workload. Tachycardia, fast heart rate, is common, but bradycardia, slow heart rate, can occur, especially with inferior MIs. You need to listen carefully to the heart for signs of heart failure, such as an S3 gallop, indicating volume overload and poor ventricular function, or new heart murmurs, like a murmur of mitral regurgitation suggesting papillary muscle dysfunction or rupture, or a harsh systolic murmur suggesting a ventricular septal rupture. Check the jugular venous pressure, GVP elevation, suggests right heart failure or volume overload. Listen to the lungs for crackles, indicating pulmonary edema, fluid in the lungs due to left heart failure. A pericardial friction rub would point towards pericarditis. Critically, check for unequal pulses or blood pressure differences between arms, or a new murmur of aortic regurgitation, which could suggest aortic dissection. The goal of the physical exam is to rapidly identify any precipitating causes, assess the hemodynamic consequences of the event, and look for clues pointing towards specific complications or alternative diagnoses.
Moving to diagnostic investigations, the electrocardiogram, or ECG, is obviously foundational in the emergency department for chest pain. What specific ECG changes are we looking for to diagnose ACS, particularly the most urgent form, STEMI?
For STEMI, the absolute critical finding is new ST segment elevation of a specific magnitude in 2 or more anatomically contiguous leads. Generally, this is 1 millimeter or more in most leads. However, there are specific, slightly higher criteria for leads V2 and V3, reflecting normal variations. In these leads, we look for 2 millimeters or more of ST elevation for men aged 40 or older, 2.5 millimeters or more for men younger than 40, and 1.5 millimeters or more for women of any age. The presence of these changes signifies acute, ongoing transmural injury and mandates immediate reperfusion therapy.
And for unstable angina or NSTEMI, which are less severe in terms of the initial ECG but still very serious, what might we see there?
For unstable angina or NSTEMI, which typically involve partial occlusion or non-transmural injury, we look for other signs of ischemia or injury. These include new horizontal or downsloping ST segment depression of 0.5 millimeters or more in 2 contiguous leads, or significant T-wave inversion greater than 1 millimeter deep in 2 contiguous leads, especially if associated with a prominent R-wave in those leads. A normal ECG, however, does not rule out ACS, especially early on or in NSTEMI way. Serial ECGs are often crucial.
And how do these ECG changes help us localize the affected area of the heart? Does the pattern tell us which artery is likely blocked?
Yes. The pattern of ECG changes across the 12 leads provides crucial clues for localization. ST elevation in the inferior leads, 2, 3, and AVF, strongly suggests an inferior wall MI, most commonly caused by an occlusion of the right coronary artery, RCA, though sometimes the left circumflex, LCX, can be involved if it's dominant. Changes in the anterior leads, V1, V4, anteroseptal leads, V1, V2, or anterolateral leads, V46I, AVL, are highly suggestive of an MI in the territory supplied by the left anterior descending artery, LAD. Lateral changes, I, AVL, V5, V6, often point to the LCX artery. Over time, ECG changes evolve. Pathological Q waves, indicating dead tissue, typically develop hours to days after an MI, and the ST segments usually normalize or flatten over weeks. These evolving changes, especially the development of Q waves, help confirm the diagnosis and differentiate recent from old infarcts.
Beyond the ECG, cardiac biomarkers are absolutely essential for confirming myocardial injury, distinguishing NSTEMI from unstable angina. What are we measuring and what's the gold standard marker now?
Cardiac biomarkers should ideally be measured in all patients with suspected ACS. The gold standard, the most accurate, sensitive, and specific markers currently available for detecting myocardial injury or necrosis in an ischemic context, are the cardiac-specific troponins, specifically cardiac troponin T, CTNT, and cardiac troponin I, CTNI. They have largely replaced the older marker, CKMB, as the preferred diagnostic test in modern cardiology due to their superior specificity for heart muscle.
What are the potential drawbacks or limitations of troponins and what's absolutely crucial for their accurate interpretation in diagnosing MI? This is a really key point for students, isn't it?
Yes, it's critical. A key drawback is their time course. Troponin levels typically don't start to rise significantly until about 3 to 6 hours after the onset of myocardial injury. So their sensitivity is relatively low in the very early hours after symptom onset. This means you absolutely cannot rule out an MI solely based on a single normal troponin level if the patient presents very early with compelling symptoms and ECG changes. Serial measurements are essential.
Okay, serial measurements.
Exactly. Also, troponins remain elevated for a prolonged period, often 5 to 10 days, sometimes even up to 14 days after an MI. While this is useful for diagnosing patients who present late, it limits their usefulness for detecting recurrent damage or reinfarction if a patient has another event soon after the first one. Crucially, for a definitive diagnosis of acute MI, according to the universal definition, you must demonstrate a characteristic rising or falling pattern of troponin levels over time, with at least one value exceeding the 99th percentile of the upper reference limit for that specific assay in a healthy population. This dynamic change, this rise and or fall, is what signifies an acute event, distinguishing it from chronic stable troponin elevation seen in some other conditions, like kidney disease or chronic heart failure. This absolutely requires a minimum of 2 measurements separated by an appropriate time interval, often 1 to 3 hours with high sensitivity assays.
So does the older marker, CKMB, still have any role at all, given that troponins are now the preferred markers?
Yes, CKMB, or the creatine kinase muscle-brain isoenzyme, does still have a niche role, primarily due to its shorter half-life compared to troponins. It typically rises within 3 to 6 hours, peaks around 12-24 hours, and returns to normal within about 48-72 hours. This faster clearance makes it potentially valuable for diagnosing reinfarction, a new MI occurring days after the initial event, when troponins might still be elevated from the first MI. A new rise in CKMB in that context would be highly suggestive of a new INT. It might also still be used in settings where rapid troponin assays aren't readily available. However, its interpretation usually requires measuring it as a ratio or percentage of the total CK level to increase its specificity. A CKMB can also be elevated slightly with skeletal muscle injury.
And myoglobin. Our sources mention it as the earliest marker to rise. What's its practical clinical utility in the ED?
Myoglobin is a small heme protein found in both cardiac and skeletal muscle. It does indeed increase very early after muscle injury, often within 1-3 hours, making it technically the earliest marker to be detected in AMI. Its main utility, though limited, is potentially for ruling out MI very early on. If myoglobin levels are completely normal in the blood within 2 to 4 hours of chest pain onset, it makes a significant AMI during that period very unlikely. However, its major drawback is its lack of specificity. It's released from any damaged muscle, including skeletal muscle after trauma, seizures, or even strenuous exercise. So, an elevated myoglobin level alone absolutely does not confirm MI. It needs to be interpreted cautiously within the full clinical context and alongside serial troponins and ECGs.
So bringing together the time kinetics of these markers, how do we interpret the levels based on whether there's true necrosis, MI, or just chest pain without muscle depth like stable angina?
Patients with true myocardial necrosis and MI will typically have cardiac marker levels, especially troponins, that rise significantly into multiples of the upper reference limit, indicating substantial cell death and release of intracellular contents. Furthermore, they will exhibit that crucial rising and/or falling pattern on serial measurements. In stark contrast, patients with chest pain but without myocardial necrosis, like those with stable angina or non-cardiac chest pain, will typically have marker levels that remain relatively normal or perhaps only slightly above the cutoff limit without that characteristic dynamic change. This distinct difference in both the magnitude and the pattern over time is key for diagnosis. Our sources also interestingly illustrate how the pattern of marker release can even suggest the success of reperfusion therapy. A sharp, rapid peak in marker levels soon after an intervention, like PCI, often indicates successful restoration of blood flow and rapid washout of accumulated markers from the damaged tissue, whereas a slower, lower, more prolonged rise might suggest less successful reperfusion.
What about BMP and NT-proBNP? These are primarily known as heart failure markers, but how do they fit into the broader landscape of cardiac disease diagnostics, especially around the time of an MI?
While they are not specific markers for diagnosing acute MI itself, B-type natriuretic peptide, BNP, and its more stable precursor, NT-proBNP, are indeed crucial markers primarily used for diagnosing and assessing the severity of heart failure. BNP itself is relatively unstable and degrades quickly after blood collection, making it less reliable, whereas NT-proBNP is much more stable, remaining viable for measurement for longer, and is therefore the most commonly used and generally preferred marker for heart failure assessment in most labs.
And their relevance around an MI?
Their main use is in the early diagnosis of asymptomatic congestive cardiac failure, or for gauging the severity and prognosis of established heart failure, which ultimately helps guide treatment decisions like use of diuretics, ACE inhibitors, etc., and aims to reduce morbidity and mortality in these patients. Elevated levels around the time of an MI can indicate significant hemodynamic stress on the ventricles and are often associated with larger infarcts, poorer left ventricular function, and a worse prognosis. So while not diagnostic of MI, they provide important prognostic information in MI patients.
Okay, so for our listeners, the third-year medical students preparing for exams and clinicals, what are the absolute key summary points to hammer home about cardiac markers? These are the must-know takeaways that will really stick.
Okay, 4 key points. Firstly, cardiac troponins, CTNT or CTNI, are the preferred markers for diagnosing acute myocardial infarction due to their superior sensitivity and specificity for heart muscle injury. Secondly, remember that in the presence of clear, typical ECG changes indicative of STEMI within the correct clinical setting, you do not necessarily need to wait for biomarker results to make a working diagnosis and initiate urgent, life-saving reperfusion treatment time is muscle. The ECG can sometimes obviate the immediate need for markers in STEMI.
Right, don't delay treatment waiting for labs in STEMI.
Exactly. Thirdly, you always need at least 2 cardiac troponin measurements separated by an appropriate time interval, minimum 1 hour, often 3 to 6 hours depending on the assay and protocol, to demonstrate the crucial rising and/or falling pattern that is required by the universal definition to confirm an acute MI and distinguish it from chronic elevation. And finally, whenever you are in doubt about the diagnosis based on initial findings, always repeat the measurements, repeat the ECG, repeat the troponins to ensure an accurate diagnosis, track the progression of injury or recovery, and guide appropriate management. Serial assessment is key.
Excellent summary. We've talked about the acute events, the cellular consequences, and the critical diagnostic tools, but none of it makes complete sense without addressing one of the fundamental root causes that often sets the stage for all of this: cholesterol. Let's really dive into cholesterol management now, which is so pivotal for long-term prevention and treatment of ischemic heart disease.
Absolutely. Cholesterol is arguably the single most pivotal modifiable risk factor in the development and progression of atherosclerotic cardiovascular disease, with incredibly strong and consistent data supporting its profound impact over decades of research. And pharmacologically, the statin drugs in particular are an absolutely pivotal drug group in management, forming the very backbone of secondary and often primary prevention therapy. You'll find that virtually all patients with some form of established cardiovascular disease, like a previous MI or stable angina, will need to be on a statin or potentially another cholesterol-lowering drug long term.
So just briefly, where does cholesterol come from? We eat it, but our body makes it too, right? And how is it transported around the body, given it's a fatty substance that doesn't naturally mix with our watery blood?
That's right. While we do absorb some cholesterol from our diet, about 75% of our body's cholesterol is actually synthesized de novo, meaning made from scratch, primarily in the liver, starting from a simple molecule called acetyl-CoA. Since cholesterol is a lipid and therefore insoluble in water and thus blood, it's cleverly packaged and transported through the bloodstream, bundled together with proteins, forming complexes called lipoproteins.
Lipoproteins, right. LDL, HDL.
Exactly. Low-density lipoprotein, or LDL, which is carried primarily by the apolipoprotein B100, ApoB, is infamously known as the bad cholesterol because high levels are directly linked to atherosclerosis development. High-density lipoprotein, or HDL, carried mainly by ApoA1 and ApoA2, is generally considered the good cholesterol due to its role in reverse cholesterol transport. Other lipoproteins like VLDL, very low-density lipoprotein, and chylomicrons from dietary fat primarily carry triglycerides, trigs, another type of fat, which are also atherogenic, contribute to plaque, though generally considered less directly harmful than LDL itself. An enzyme called lipoprotein lipase, found on blood vessel walls, then cleaves these triglycerides from VLDL and chylomicrons, allowing the fatty acids to be taken up by tissues like muscle and adipose tissue for energy or storage.
What's the direct link then between high LDL levels circulating in the blood and the development of atherosclerosis and ultimately MI or stroke? How does that bad cholesterol actually wreak its havoc inside our arteries?
A higher LDL concentration in the blood directly correlates with a significantly increased risk of cardiovascular disease. Our sources suggest it contributes to potentially 50–70% of MI risk, and it also has a very high correlation with thromboembolic stroke risk. Increased LDL leads to its infiltration and deposition in the intima layer of arteries, especially the coronary arteries supplying the heart and the carotid arteries supplying the brain. This deposition initiates and fuels the formation of an atheroma, or plaque.
Okay.
This atheroma isn't just inert fat. It triggers a chronic inflammatory reaction, recruiting those macrophages and neutrophils we talked about. These cells engulf the oxidized LDL, becoming foam cells. These foam cells accumulate, contributing to the growing unstable lipid core of the plaque.
And when atheroma ruptures, as we discussed earlier in the context of ACS, what's the fatal cascade that follows from a cholesterol perspective?
When that unstable atheroma, rich in lipids and inflammatory cells, ruptures its thin fibrous cap, it exposes the underlying highly thrombogenic material within the plaque, especially tissue factor, to the circulating blood. This immediately initiates the coagulation cascade, leading to the formation of a thrombus or blood clot. This clot can then partially or completely occlude the artery, resulting in an acute MI if it's in a coronary artery, or a thromboembolic stroke if it happens in a carotid or cerebral artery and the clot travels to the brain. Despite all other health challenges, atherosclerotic cardiovascular disease, driven largely by factors like high cholesterol, still remains the leading cause of premature death worldwide.
And there's more to it than just physical blockage, right? Doesn't high cholesterol also damage the endothelium directly?
Yes, absolutely. Endothelium that is damaged or dysfunctional due to chronic exposure to high cholesterol cannot produce enough nitric oxide, NO, which is an essential endogenous vasodilator, or prostacyclin, which is both a vasodilator and inhibits platelet aggregation. This impaired endothelial function leads to increased propensity for vasoconstriction and increased platelet aggregation, further contributing to the disease process and making acute events more likely.
So lowering LDL isn't just about preventing new plaques from forming. You mentioned earlier it can actually reverse existing ones and make them safer. That's quite a powerful concept for patients to understand.
Absolutely. This is one of the most exciting and motivating aspects of modern lipid management, strongly supported by imaging studies. Lowering LDL cholesterol significantly, particularly down to very low levels, often targeting below 1.8 millimole or even lower in very high-risk patients, not only dramatically reduces the incidence of future MIs and strokes, but can also stabilize existing stable coronary artery disease. More remarkably, intensive LDL lowering has been shown to actually cause regression of atherosclerotic plaque volume over time. It appears to thicken the protective fibrous cap, making the plaque less likely to rupture, and it can even shrink the overall size of the plaque itself. This potential for plaque stabilization and regression is a major reason why aggressive LDL lowering with statins is so vital after an ACS event and in high-risk individuals.
So what are the target cholesterol levels we're actually aiming for in patients? Is it a fixed number for everyone, or is it more individualized now based on risk?
The current treatment paradigm, especially in recent guidelines, places less emphasis on achieving fixed absolute target LDL levels for everyone and more emphasis on achieving a significant percentage reduction of LDL from the patient's baseline level, typically aiming for a 40–50% or even greater reduction depending on the risk category. However, there are still target levels often recommended based on the patient's overall cardiovascular risk.
Can you give some examples?
Sure. For moderate risk patients, that might include people with type 1 diabetes with microalbuminuria, many patients with type 2 diabetes who are considered a risk equivalent to having had a prior event, patients with severe genetic lipid problems, or those with an estimated 10-year cardiovascular disease risk around, say, 10–20%, the aim is often an LDL below 2.5 millimole or 100 milligdl. This frequently requires statin therapy in addition to lifestyle changes. For low-risk individuals, the target LDL might be less stringent, perhaps below 3.2 millimole, 116 milligdl, which maybe half can achieve with dedicated lifestyle changes alone. However, for very high-risk patients like those with established atherosclerotic cardiovascular disease, for example, previous MI, stroke, peripheral artery disease, those with familial hypercholesterolemia, or severe diabetes with end-organ damage, the target is much more aggressive, aiming for an LDL below 1.8 millimole, 70 milligdl, or even below 1.4 millimole, 55 milligdl, according to some recent European guidelines. Achieving these very low targets almost always necessitates a high-intensity statin, often in combination with other therapies.
You mentioned familial hypercholesterolemia, or FH, as a very high-risk group. What exactly is that condition, and how does it so clearly illustrate the powerful genetic link between cholesterol levels and premature heart disease?
FH is a fascinating and unfortunately relatively common genetic condition where individuals inherit defects in the gene responsible for the LDL receptor. This means their liver cells have an insufficient number of functional LDL-C receptors on their surface, impairing their ability to effectively clear LDL cholesterol from the blood. The rare homozygous form, where both copies of the gene are defective, leads to extremely high circulating cholesterol levels from birth, often LDL 13 millimole or 500 milligdl, and a very high correlation to early severe MI. Before effective treatments like statins became available, these patients often developed severe coronary artery disease by age 12–13 and tragically died in their early 20s.
Wow. And the heterozygous form?
The heterozygous form, where only one copy of the gene is defective, is much more common, affecting perhaps 1 in 250 people. It still results in significantly high circulating LDL levels throughout life. Typically LDL between 5–10 millimole or 190–400 milligdl. These patients require aggressive management, often starting with very high doses of statins, sometimes combined with other drugs like ezetimibe or PCSK9 inhibitors, to effectively increase the expression and function of what few normal receptors they have. With appropriate early diagnosis and lifelong therapy, these individuals can now often live much longer, healthier lives, reaching their 60s and 70s, but their lifetime risk remains very high without treatment. Physical signs like xanthomas, cholesterol deposits in tendons, especially the Achilles, or xanthelasmas, deposits around the eyes, can sometimes be a key clue to this diagnosis, especially if seen at a young age.
And HDL, the good cholesterol, it sounds more complex than simply the higher the better. What's the challenge there in terms of targeting it therapeutically? Why haven't we got a magic pill to raise HDL?
Yeah, HDL's story is definitely more complex. Its primary proposed beneficial role is in reverse cholesterol transport, picking up excess cholesterol from peripheral tissues, including macrophages within atherosclerotic plaques, and transporting it back to the liver for excretion, often via transfer to LDL particles first. However, HDL is biologically complex. There are different subtypes defined by their apolipoproteins, primarily ApoA1 and ApoA2. Research suggests that only the ApoA1 containing HDL particles are consistently associated with cardiovascular protection. ApoA2 containing HDL may even be neutral or potentially pro-atherogenic.
So drug development has been tricky.
Very tricky. Despite initial optimism and huge investment, attempts to significantly increase HDL levels pharmacologically, for example, with drugs targeting the enzyme CETP, cholesterol ester transfer protein, have largely failed in major clinical trials. Some trials were stopped early due to lack of benefit or even evidence of increased mortality. This might be because these drugs raised all HDL, including potentially the less beneficial or even harmful ApoA2 containing subtypes, or had other off-target effects. For now, non-pharmacological approaches like regular aerobic exercise, stopping smoking, which is known to dramatically reduce beneficial HDL levels, maintaining a healthy weight, moderate alcohol intake for some, and adhering to a Mediterranean-style diet have proven more consistently successful at boosting beneficial HDL levels, although the impact is usually modest. Low HDL remains a risk marker, but directly targeting it pharmacologically has proven elusive so far.
So let's get to the core pharmacological strategies for lowering LDL cholesterol, which we know works. Statins are obviously number one. How exactly do they work their magic at the molecular level? And what are their most important adverse effects clinicians and patients need to be aware of?
Right, statins or HMG-CoA reductase inhibitors are our primary and most effective weapon against high LDL cholesterol. Their mechanism of action is really quite clever. They competitively inhibit the enzyme HMG-CoA reductase. This enzyme catalyzes a critical, early, rate-limiting step in the liver's own cholesterol production pathway,
Right.
synthesizing mevalonate. By blocking this enzyme, the liver cell senses that it's not producing enough cholesterol internally.
Okay.
In response to this perceived cholesterol deficit, the liver cell increases the number of LDL receptors it expresses on its surface. These increased hepatic LDL receptors then act like powerful magnets, efficiently binding to and clearing LDL particles from the bloodstream, internalizing them into the liver. This causes a dramatic drop in circulating LDL levels, often visible within just a few weeks of starting therapy.
And their potency varies. You mentioned not all statins are created equal in terms of LDL lowering.
Yes, their potency varies significantly, which guides our prescribing choices and dosing. Rosuvastatin is generally considered the most potent on a milligram per milligram basis, followed by atorvastatin. For context, our sources note that a 5 milligram dose of rosuvastatin might achieve a similar LDL reduction to 10 milligrams of atorvastatin, or perhaps 20-40 milligrams of simvastatin or pravastatin. While higher doses of statins exist, often up to 40 milligrams for simvastatin or 80 milligrams for atorvastatin and rosuvastatin, the LDL lowering effect tends to plateau at higher doses. You get diminishing returns while the risk of adverse events increases. So very high doses are used more cautiously. But overall, statins are unequivocally shown to lower LDL cholesterol, increase hepatic LDL receptors, reduce the progression and sometimes cause regression of atheroma, thicken the protective fibrous cap, making plaques more stable, and most importantly, reduce major cardiovascular events like MI and stroke. They are absolutely essential therapy for most patients with established cardiovascular disease or those at high risk.
What about their adverse effects, particularly the muscle-related ones that patients often worry about?
Muscle-related side effects are the most commonly reported adverse events. These can range from mild myalgia, muscle aches or soreness, without any significant muscle damage, which is relatively common, perhaps affecting 5–10% of patients, up to more severe myopathy, muscle weakness with elevated CK levels, and finally, the very rare but potentially fatal complication of rhabdomyolysis.
Rhabdomyolysis, that sounds serious.
It is. Rhabdomyolysis involves the severe breakdown of skeletal muscle protein, myoglobin, which gets released into the bloodstream and can overwhelm the kidneys, causing acute kidney failure. This is extremely rare, estimated to occur in maybe 1 in 100,000 patients per year on statin therapy. The risk is higher with higher doses in elderly patients, those with kidney or liver disease, and significantly increased when statins are combined with certain other drugs, particularly fibrates, another class of lipid-lowering drugs, or certain antifungals and antibiotics that interfere with statin metabolism. Myalgia is much more common and often dose-related. While bothersome, it's usually manageable by reducing the dose, switching to a different statin, or trying intermittent dosing, but it can unfortunately lead to persons discontinuing this life-saving therapy. There can also be a transient, usually mild, increase in liver transaminases, liver enzymes, but significant liver toxicity is very rare, and routine monitoring of liver enzymes is generally no longer recommended for most patients unless there are specific clinical signs or symptoms of liver problems, as these elevations usually normalize on their own or with dose adjustment.
What about other older drugs like cholestyramine? Is it still used much, or has it been largely replaced by more effective and tolerable options?
Cholestyramine is a bile acid sequestrant, one of the oldest classes of lipid-lowering drugs. It's essentially a large, non-absorbable resin powder that patients mix with water or juice. It works by binding bile acids in the intestine, preventing their reabsorption back into the liver via the enterohepatic circulation, and thus promoting their excretion in the feces. Since bile acids are made from cholesterol in the liver, this forces the liver to synthesize more bile acids, using up intracellular cholesterol. This, in turn, prompts the liver to increase its LDL receptors by about 15–20% to pull more cholesterol from the blood.
But it's not very effective on its own.
By itself, it's not very effective for a significant LDL reduction compared to statins, maybe lowering LDL by 15–25%, and it has notoriously poor patient tolerance due to gastrointestinal side effects like bloating, constipation, and its unpleasant gritty texture, often described by patients as like drinking orange-flavored sea sand. It also interferes with the absorption of many other medications, so it has a very limited role now, primarily used occasionally as an add-on therapy in patients with very high cholesterol, like FH, who are already on maximum statin therapy, or sometimes in patients who absolutely cannot tolerate statins at all, but it's rarely used as a first-line or single agent anymore.
Then there's ezetimibe. How does that work, and is it used alone or typically with a statin?
Ezetimibe works differently. It selectively inhibits cholesterol absorption at the brush border of the small intestine by blocking a specific cholesterol transport protein called NPC1L1, Niemann-Pick C1-like 1 protein. This reduces the absorption of both dietary cholesterol and cholesterol secreted in the bile. By reducing the amount of cholesterol delivered back to the liver, it also leads to an upregulation of hepatic LDL receptors, similar to bile acid sequestrants, further lowering circulating LDL. It also seems to have a synergistic effect with statins, possibly by increasing the sensitivity of the HMG-CoA reductase enzyme to statin inhibition, although the exact mechanism isn't fully clear.
So combination therapy is key.
Yes, ezetimibe is not considered sufficient as monotherapy for most patients, typically only reducing LDL by about 15–20% on its own. However, it's used very effectively and commonly in combination with statins. Adding ezetimibe to a statin generally provides an additional 15–25% LDL reduction on top of what the statin achieves, which can be crucial for getting high-risk patients to their very low LDL targets, or allowing the use of a lower, better-tolerated statin dose. It is generally very well tolerated with few side effects beyond occasional mild GI upset.
And finally, the newer kids on the block, PCSK9 inhibitors. What makes them so powerful and promising?
PCSK9 inhibitors are a relatively new and very exciting class of injectable biologic drugs, monoclonal antibodies. They work by targeting a protein called PCSK9, proprotein convertase subdeletion kexin type 9. Normally, PCSK9 binds to LDL receptors on the liver surface and targets them for degradation inside the cell. By inhibiting PCSK9, these drugs prevent the degradation of LDL receptors, meaning more receptors remain active on the liver surface, available to clear LDL cholesterol from the blood.
So they dramatically lower LDL.
Yes, the effect is dramatic. They can lower LDL cholesterol by an additional 50–60% on top of statin therapy, often achieving extremely low LDL levels, sometimes even down to 0.4–0.5 millimol, 20 mg/dL. They have shown clear benefit in reducing cardiovascular events in high-risk patients in major clinical trials. They are currently used primarily for patients with FH or those with established cardiovascular disease who cannot reach their LDL goals despite maximum tolerated statin therapy, often with ezetimibe. Their main drawbacks currently are their high cost and the need for subcutaneous injection every 2 or 4 weeks. Our sources also briefly mention fibrates as another older class of lipid-lowering drugs, primarily used for lowering high triglycerides, noting their increased risk of myalgia and rhabdomyolysis when combined with statins, but without going into further detail on their specific mechanisms or broader use in the context of ACSMI prevention.
So we've covered a tremendous amount of ground today. Really, from that initial scenario of acute chest pain, right through to the intricate cellular mechanisms that underpin ischemia, the different types of angina, the critical diagnostic pathways using ECGs and biomarkers, and the multi-pronged pharmacological strategies, antiplatelets, anticoagulants, reperfusion, and long-term cholesterol management used to tackle these complex conditions.
The critical takeaway for you, as third-year medical students heading towards exams and clinics, is really the profound interconnectedness of it all. You've seen how chronic processes like atherosclerosis, driven by risk factors like cholesterol, can lead to acute plaque rupture, triggering cellular ischemia and necrosis, which then manifests clinically as ACS, requiring specific diagnostic tools like troponins and prompting both immediate interventions like PCI and long-term treatments like statins. Understanding the why at every single level, from the population risk factors down to the molecular pathophysiology, is truly essential.
And that comprehensive understanding is precisely what you need to succeed, not just to ace your upcoming exams, but to be a competent physician. It's not just about knowing the facts in isolation. It's about understanding the underlying processes, the cause and effect relationships, the physiological and pathological responses, and how they all logically fit together to guide your clinical reasoning.
Indeed. This isn't just rote memorization. It's about building a robust clinical framework in your mind, developing that deeper level of understanding and clinical intuition that will serve you incredibly well in both your assessments and, much more importantly, in your future clinical practice when you're faced with real patients.
As you continue your studies and integrate all this information, perhaps consider this provocative thought for the future. How will the ongoing revolution in personalized medicine, driven by advances in genetic insights, like identifying FH early, sophisticated imaging, and real-time biomarker monitoring, further refine how we diagnose, risk stratify, and treat cardiovascular disease? We're already seeing the beginnings of highly targeted treatments like PCSK9 inhibitors. Imagine a future where we can even more precisely tailor prevention and therapy to an individual's unique risk profile and pathophysiology, potentially preventing so much suffering from these common and devastating conditions.
It's a fascinating prospect, and it's a field that's constantly evolving. It will undoubtedly shape the future of cardiology and internal medicine in the years to come.
We really encourage you to review this deep dive. Maybe listen again, connect the concepts to your lectures and textbook readings, and be prepared to apply this knowledge. The more you truly understand these underlying mechanisms, the more effective, confident, and ultimately compassionate a clinician you will become.